Okay, so in this section here, what I want to do is I want to go over some clinical cases and really take the information that we've been going over this throughout this course and put it into real life settings. So we went through all the different physiological mechanisms, went over the research in diet, nutrition, lifestyle, and environmental triggers, pathogenic triggers. We went through a step-by-step approach, how to evaluate the patient, and how to clinically manage the patient as well. So let's go over first case. So first case, patient comes in, and the chief complaint is extreme fatigue, cognitive brain impairment, and chronic pain and joint inflammation. So this was actually, let me tell you what happened with this. A really good friend of mine from when I was younger and in college called me up and said, "Tees, I'm not feeling well. I don't know what to do. My doctors aren't giving me any clear answers, and I'm really scared, and I'm not functioning, and I don't know what's going on." So I said, "All right. Let me send you a lab requisition form. I'll email it till you go get some lab work done." So we get lab work, and this is his test results. Now, let me just go back for a second. Just the fact he's got extreme fatigue doesn't really tell us much, but it's the potential that he has a blood sugar disorders. And, cognitive brain impairments, there's so many things that this could be, and this is really where lab testing shines. Now, first thing you should notice when we look at his lab results is if you take a look at his fasting first of all, he's not fasting. In a non-fasting state, his glucose is below 63. So right away, that's not functional hypoglycemia. That's pathology. There's something wrong with him. There is something not allowing his blood sugar levels to go up. So this could be liver disease. This could be kidney disease. This could be nothing good. So this is immediately a red flag. So right away, the first marker, we see he's not fasting. I see he's not fasting, and glucose is not there. So I immediately know that this is very serious. We look at the hemoglobin A1C. Look at this level. It's 6.4. So he's got severe oxidative stress, severe glycolation. He's got severe free radical activity happening here. And we look, this pathway is, associated with basically diabetes, but his liver, but we can see later on that he's got some dysfunction in his organ system and his kidneys that's not allowing his glucose to be stabilized. So as we go down the markers, immediately see his BUN level is high. Creatinine levels are high. These are associated with kidney disease. The liver makes BUN, the kidneys clear it. So we're not getting clearance here. Creatinine is a byproduct of muscle metabolism. The kidneys aren't able to clear it, so those are high. His glomerular filtration rate is 30. This is stage 3 levels of kidney disease. If he has the proteinuria, then we know he's got stage 3 kidney disease. Once you get on stage 3 kidney disease, you have to have dialysis or you can die. We look at his chloride levels, they're very high. His CO2 levels, calcium are very low. Total protein is really low. Albumin is really low. This is progressed kidney, this is severe kidney disease. Look at bilirubin levels, pretty high. LDH, really high. LDH, we know low can associate with hypoglycemia, but lactic acid dehydrogenase is found in many tissues, and it's also found in renal tissue. So if the kidneys are injured and breaking down, then you can have these high levels. So then we go on the second page. His iron binding capacity is low, but look at his ferritin. Ferritin is an acute phase reactant for inflammation. His ferritin levels are 1,220. That is significantly high. He's in a high degree of inflammation. Cholesterol levels high, triglyceride levels high. His homocysteine levels are 13.4, which are borderline. Thyroid is working okay. And vitamin D levels, look at this, 8.7. I mean, extremely, extremely low. Fibrinogen activity leading to strokes and heart attacks, 781. Red blood cell, hemoglobin, hematocrit, extremely low. This is normocytic, normochromic anemia, secondary to kidney disease. And then we look at his serum protein. His serum protein levels are 4. And he's got some little small granular cast in here. So this lets us know with his GFR being low, he's in confirmed stage 3 kidney disease. So this is right here. This is diabetes with nephropathy. This is the extreme. This is the end of the range. And at this point, I called him, I got the test results back. I called him back. He just tells me he was in the emergency room. He just had a stroke, which is not surprising because, and this is, the stroke was caused by these metabolic imbalances. His fibrinogen levels were so high. So this is a person, I mean, when I look at this lab result and you look at it, you can see that this lab result really reflects a diabetic pattern with kidney disease to the point where they have significant kidney disease that the kidneys can no longer stabilize blood sugar levels. So this is as ugly as it gets. And at this point, the immediate first thing was he got his stroke managed in acute care, and they just released him. And they didn't say any follow-up care. So we had to make sure he connected with his doctors and really started dialysis. Now, what's this person's history? What's interesting about him is he was in the Navy and he used to work with demolition team, and he used to tell me he used to swim with chemicals all the time, and many times he'd be on a project and leave and he would taste chemicals in his mouth for weeks and weeks at a time. So it seems like, you know, over a period of time as he's gotten older, some of these toxic things have happened, and he's kind of just been ignored in the healthcare system, and he's really at the point where he needs immediate care with dialysis, and he needs to go on a renal disease diet. And this is now at the extreme where it's not really a functional medicine model. This is he's really at the point where he needs acute crisis care. So this is acute crisis care. So this is exactly the worst scenario. You see high HbA1c, high acute phase reactants, stage 3 renal disease, and this is at the end of the spectrum. So, and to be quite honest, I don't have much to offer him. I don't really have any great strategies for him. Really right now, I just want to make sure that he can get the proper medical management he needs, and he needs to be, managed through those pathways. When we look at the diabetes web of complications, his HbA1c is significantly elevated. He's really has injured his kidneys. He can't clear advanced glycation end products at this point. He's got severe electrolyte imbalances. He's hypertensive with high fibrinogen. He just had a stroke. And, if I had a chance to do an exam on him, we probably wouldn't be surprised to see any of these other types of neurological deficits as well. So that's the worst case scenario case. So just wanted to share that with you so you can see the extreme and how those look. Now, let's go into second case. He's doing okay, by the way. He's stabilized. He's getting medical attention right now. And his spirit has improved. His energy has improved. But the key thing was the healthcare system completely ignored him. And even when he had a stroke and he was released, he was not referred out to a nephrologist. So this is sometimes what happens with poor healthcare. But in any case, that's case one. Okay, let's go into case two. Now, case two is a scenario of a patient that had latent autoimmune diabetes of adulthood, celiac disease, and insulin ataxia. And this was a case where a patient came in and they were diagnosed with type 2 diabetes and a family history of celiac disease, and they had gluten ataxia. They were diagnosed initially with celiac disease at UCLA. And this was a case that I actually published as a case study in the journal Case Reports. And the title of the paper is Gluten Ataxia Associated with Dietary Proteins Cross-Reactivity GAD65. So if you just Google this title, you'll have the paper come up in the full case reports there for you to read if you're interested in reading it. But let me summarize the key points of this case report. So the medical history of this patient was a 42-year-old male with chief complaints of dizziness, instability, nausea, cognitive decline, was previously diagnosed with celiac disease. The patient had adopted a gluten-free diet for the past 3 years. These dietary changes had improved his gastrointestinal complaints, cognitive function, and his overall health significantly. In recent months, he has noted limb tremor, postural instability, especially while walking downstairs, and sporadic ataxia. Recent laboratory tests demonstrated development of diabetes that was diagnosed as elevated HbA1c, levels above 6.1, normal is 5.7. So a couple things about this case. He actually had latent autoimmune diabetes in adulthood, but he was misdiagnosed. And this is at one of the top medical universities in the world. This happens all the time. And really, he got to the point where he was starting to have posture instability. Like if he would get into a Romberg's test, he would just start to titubate like this, and it kept getting worse and worse. And with gluten ataxia, technically, if you go off gluten, you should be 100% better. And so we have this co-expression of celiac disease, which is one autoimmune disease. And later on, we found that he had GAT65 antibodies, which is type 1 pancreatic autoimmune disease. And remember, GAT65 also cross-reacts in the brain. So physical examination findings identified patterns associated with both midline and lateral cerebellum degenerative diseases that include a positive Romberg's test, termination tremor with targeting of the limbs, dysglycemia, and repeated coordinated movements, hypermetric saccades. So on exam, like when you put him on a Romberg's test, he has no stability. Close his eyes, he's about to fall. Termination tremors when you try to target and you start to shake before. And then dysdiadokinesia when your hands are not able to coordinate. And hypermetric saccades is when you target two different visual fields, the eyes have movement that's like that. There were no other abnormal findings. His motor sensory pathways are intact. It was very clear it was just the cerebellum, and there's no other patterns of disease. And these were the summary of all his lab tests. His MRI was normal. Myelin basic protein antibodies were normal. But look at this. GAD antibodies elevated, islet cell antibodies elevated, S100B levels elevated. So this is blood-brain barrier permeability and type 1 diabetes. GAT65 also is involved with gluten ataxia because GAT65 is found in the pancreas and found in the brain. His SIGA levels were elevated, fecal hemoglobin A1C was elevated, fasting glucose was elevated, triglycerides, cholesterol were elevated, and then he had markers for gluten antibodies. Now, we put him through Cyrex Array 10 to check for food sensitivities because I wanted to see which foods cross-react with GAT65. And these are the foods that cross-reacted with GAT65 and islet cell antibodies. So these were also elevated. So he has autoimmunity to GAT65 for his pancreas, misdiagnosed as type 2 diabetes, actually has latent autoimmune diabetes adulthood. And if you remember the vicious cycle of autoimmune diabetes, one of the areas where you can have co-expression of autoimmunity in this pancreas and with GAT65 in the cerebellum. So this is exactly what this case scenario was. And what I did is I looked at the food proteins that were cross-reactive islet cell antigens GAT65, and we looked at the foods that cross-reacted with those proteins from the study we published in the Journal of Diabetes Research. And then we removed these foods out of his diet to stop the molecular mimicry, and we had some profound change in his response, a really positive outcome. So the patient was placed on a restrictive diet to avoid these cross-reactive foods. Within the first 6 months, the patient noticed significant change in his cognitive function and stability. He no longer had any symptoms of dizziness. Follow-up testing identified an improvement in his serum HbA1c levels and significant change in his physical examination findings. There was a significant improvement in his balance and patterns of both truncal and limb ataxia. The patient continued this diet for an additional 6 months with no relapse and continued to improve with no identifiable pattern of ataxia or progression of his autoimmune disease. HbA1c returned to normal. So that was all published recently in the journal Case Reports. But the reason this case is important, and the reason I wanted to publish this, and the reason the reviewers of this paper thought that this was worthy to publish was a couple things. Many people that get diagnosed with gluten ataxia have the same co-expressed GAT65 antibody in their pancreas, and also they have it in their islet cells. So first of all, this illustrates the point that many people that have gluten ataxia that get diagnosed with diabetes are actually patients that have latent autoimmune diabetes of adulthood that gets missed. So that was the first key point of this case study. The second key point of this case study is that gluten-free was not enough because GAT65 cross-reacts with other foods. Now, the fact he has celiac disease means he has an HLA-DQ genotype that makes him extremely sensitive to gluten proteins and has an exaggerated T-cell response compared to people that don't have celiac disease. But in addition to gluten, the other food proteins that also cross-react with GAT65 are important. And this was the first case report published in the literature that really showed that these other cross-reactive foods have an impact clinically. Now, for me, this was exciting because we did the initial research to find these cross-reactive foods and published this about 3 years ago. And then here we were able to show the clinical significance of an actual case study having these effects. And I think if you start to implement things we taught in this course of looking at type 1 diabetics, that then find out which target proteins that cross-react and you remove the molecular mimicry food, you're going to see some nice change that many people may not do in the healthcare system because they don't understand these mechanisms and these research. So case number 2 was a latent autoimmune diabetes of adulthood with gluten ataxia, cerebellar autoimmune reactions that had the biggest change with a gluten-free diet and cross-reactive foods. So those are the principles that we talked about in the course so far. So that's something I wanted to share with you as case number 2. Let's get into case number 3. So case number 3, female patient, 46 years old, and these are her chief complaints. And these are just cut and paste from the office forms I have in my office. Hair thinning, intermittent fatigue. So she's currently on lidothioridine. She has ulcerative colitis, she has Hashimoto's, she's on an asthma inhaler, and she's currently in remission with her ulcerative colitis. She takes 1,000 milligrams of fish oils every day and some oriental medicine tea for her hot flushes. So that's her chief complaint. Now, she's seen many practitioners, tried many nutritional supplements, but her main complaint was just her energy levels are fluctuating all throughout the day, and she has continued hair thinning despite being on thyroid replacement, having a thyroid monitored all the time. This is the initial paperwork. This is just a questionnaire form that I use in my office that goes over symptoms. We've gone over this form in other courses, but hair loss, fatigue, sugar cravings, and always tired. This is how she fills out the form. And then if you look down here, there's a scale here from 0, 1, 2, 3, 0 to 3. 3 means they have the symptoms almost all the time. 2 is frequent, 1 is occasional, and 0 is they have no symptoms. If you can see here, she craves sweets during the day. She's irritable if meals are missed all the time. That's hypoglycemia. The fact she writes down sugar cravings, that's hypoglycemia. Fatigue, always tired. She also writes eating sweets does not relieve sugar cravings, and must have sweets after meals. So these are all strong indications she has some type of hypoglycemia pattern. She has afternoon fatigue. She gets some dizziness when she stands up quickly. She wakes up tired even after 6 hours of sleep. These symptoms here are associated with the thyroid. She has some thyroid autoimmunity, but her autoimmunity seems to be under control for the most part. She's not progressing with her ulcerative colitis. Her TSH levels have been pretty stable over time, but these key symptoms indicate that she has some type of hypoglycemia or maybe even potential insulin resistance pattern. Remember that hypoglycemia hypoglycemia has some degree of insulin resistance. Insulin resistance has some degree of hypoglycemia. So when we're kind of done listening to her history and workup, we kind of lean towards hypoglycemia, but it could be either. Now let me tell you her frame. She's underweight. So the fact she's underweight and having these symptoms, it strongly leans to hypoglycemia. So this is what her lab work looks like. Look at her glucose. Her glucose is 65. It's right on the border of whether do you think it's pathology or do you think it's a functional pattern. And the great thing with having complete blood work is you can go through it and realize that there's no indications of pathology or disease here besides the ulcerative colitis. And we don't see any changes in her kidney function, her liver function, her electrolytes are okay. So that rules out some significant patterns of metabolic disease. Now her LDH is also below 140. So LDH below 140, glucose below 85. She's still within the normal reference range, but just barely. These are indicating a hypoglycemia pattern. Her cholesterol is a little high, her LDL is a little high. This is not uncommon when people have thyroid disease. Thyroid hormones help clear thyroid hormones, and despite the fact she's on it, this is just some very minimal elevations outside the laboratory reference range. No patterns of anemia. She doesn't have any acute phase reactant responses. Here's her Hashimoto's, DPO antibodies high, thyroglobulin levels high. Her eosinophils are high because one of the things that happens with ulcerative colitis is you get mast cell activation. So that's expected when people have ulcerative colitis. And, she's got some alkaline urine, which can also take place. She had symptoms of respiratory issues. So we checked her for reactions to mold. She had significant reactions to every single mold species pretty much we tested. So she's got some immune reactions there. I just evaluated her histamine levels in her blood, significantly high. Histamine levels in plasma, significantly high. These are based on the ulcerative colitis immune response and mast cells and some of these environmental issues. So now I've got a patient who I would suspect has hypoglycemia, doesn't have pathology to her liver system or organs, but her ulcerative colitis is creating significant inflammation, and this may be what may be impacting her blood sugar levels. Now, I'm really interested in her diet because I got to go, does she have a diet that justifies being hypoglycemic or does she not? Now, let me just say it this way. If you go through her dietary history as a patient and you find out she's eating every few hours, high amounts of protein, high amounts of fat, and she has to do that to stabilize her blood sugar, you're probably going to assume that her ulcerative colitis, her inflammatory condition is really promoting her hypoglycemia. But if you look at her diet and look at her blood sugar levels, and she's actually having a diet that promotes hypoglycemia, then you're more likely to think that this could just be its own independent factor. So here's I wrote her symptoms down on this form that we've been using on this course for the slide. So she wakes up 5:30 a.m. and in the morning she has smoothie with fruit and almond milk. And this is actually her diet, yeah. Gluten-free toast and jam, cranberries and raisins, salads with chicken, an apple, steamed veggies and chicken, 1 piece of dark chocolate, and then she goes to bed, and then she usually wakes up between 1 to 3 o'clock. So right away, this tells me that her diet justifies being hypoglycemic. So I'm leaning more towards a functional hypoglycemia due to blood sugar resiliency, even though her blood sugar level is really on the borderline of being on the pathological range, just not finding any significant signs of pathology. However, I have to be concerned about her ulcerative colitis. So this was actually what I wrote in her report. And let me just I guess I can read it to you really quickly. The impression is she's currently suffering from 2 identified autoimmune diseases, which include Hashimoto's hypothyroidism, ulcerative colitis. These autoimmune diseases appear to be in stable patterns, and there's no signs of progression. There's been no requirements to increase the thyroid medication. TSH levels have been consistently within range since the diagnosis. There appears to be some underlying inflammatory reactions occurring with the expression of ulcerative colitis. Recent laboratory tests identified neutrophil percentage 11.5%, elevated calprotectin levels. These laboratory markers will be reevaluated by our gastroenterologist in 4 months. There's possibility that our elevated histamine levels induced by mast cell activation of neutrophils from ulcerative colitis may also play a role in their hair thinning. Mast cells and histamine cause hair thinning, and so does hypoglycemia. Serum and whole blood histamine levels, in addition to neutrophil levels, have been monitored throughout the case. There are some clear patterns of functional hypoglycemia that appear to be leading to fluctuations in energy levels and may be a role in increasing circulating insulin surges that promote potential hair thinning. Patterns of blood sugar fluctuations may also be playing a role in our inability to stay asleep throughout the night and frequent nocturnal urination 2 times a night. Also, medical history of chronic mold exposure and potential exaggerated immune responses to mold species. These patterns may be associated with potential risk factors for chronic inflammatory sinusitis and intermittent asthma, which she also complained about. And there appears to be poor patterns of circulation, especially in the lower extremities, is evident with examination findings of reduced surface temperature in distal tissues compared to the proximal tissues of the limb. There's a 4-degree Fahrenheit difference between temperatures on her scalp compared to the trunk, which suggests that impaired circulation may be playing a role in her hair thinning. And we put once she has improved her energy levels and physical activity, will be recommended to encourage improved circulation, healthy vascular dynamics. It appears that she has transitioned to menopause with some ongoing symptoms of hot flushes. Serum FSH levels were measured at 2016, identified elevated FSH, and within the postmenopausal range have also been no menstrual cycles since May 2018, so she's in postmenopause. So the protocol we put her on is, I basically gave her a diet to manage and stabilize her blood sugar levels, just like we talked about in the course. Eat more frequently, eat every 2 hours, make sure you eat frequently enough so you don't have symptoms of blood sugar improvement as soon as you eat. You should have no change in your energy levels after you eat. If you're eating frequently enough, you should just feel like your appetite's satisfied, and make sure you get enough protein so you can sleep through the night. And then we had her also take some tablespoons of diverse vegetables like a veggie mashup we talked about in the autoimmune course just to help her gut. I put her on a product called ProGlyco-SP, which is basically B vitamins and supplements that help stabilize blood sugar levels that are important for hypoglycemia. I put her on a product called Enterovite, which is short-chain fatty acids. These are all from Apex. I put her on a product called Repairvite to help just support her gut because she has really no support for gastrointestinal system, and I want to reduce her inflammation. And then we did some of the strategies we talked about with mold and the autoimmune course that she was following. So she basically, the goal was to reduce her fatigue and energy levels and see how if we can reduce her sugar cravings, see if that's any impact on hair thinning, and then see if it has any impacts on her sinus inflammation. So here's the follow-up testing. Look at her glucose levels. Let's see the date here. Yeah, so this is about 6 months later. We got her glucose levels back up to 87. Her LDH levels are back up to 141. Cholesterol levels are now a little bit higher. Eosinophils are still a little bit high. And she's feeling a lot better. And this is her email to me. Hi, Dr. K. Want to email you to let you know that the supplements were working great. They've really helped. Unfortunately, my hair loss has not subsided. In fact, it seems worse. I feel like I'm living with my best life and as healthy as ever, except for this. I know we discussed this at the beginning of my journey. This may not help anything, so I understand. I guess my question is there anything else I should be doing? So when I work with patients with hair thinning and hair loss, I usually tell them that is not the focus of my care. My focus is just to improve your health. We can try everything and maybe it'll make a difference or not. So at this point, her energy levels are 100%. She's feeling great. She's mentioning she's feeling better than she ever has just by stabilizing her blood sugar levels. And then at this point, I said add 3,000 milligrams of quercetin. Quercetin has a major impact on histamine expression. That could be one of the reasons that her hair loss is happening from her ulcerative colitis causing those mast cell activations. So some things are better, some things aren't better, but this is a real case, and that's as far as we are with it. But I just wanted you to see how the glucose levels change, and a case of hypoglycemia that's kind of borderline, and how the implementation of some of the things we talked about in this course had a pretty good impact on her blood sugar levels and their stability. Let's go to case number 4. Case number 4, 36-year-old female. Chief complaints: anxiety, depression, lack of focus, concentration, attention deficit, impaired reading, and concentration. So this was a female patient that I had consulted with me, and she was extremely intelligent, but she was constantly suffering from anxiety, depression, and brain fatigue and brain concentration issues. So she came into the office, and by the way, she was underweight, and that makes me suspect she's hypoglycemic. In her dietary history, she misses meals regularly, and basically she has all the symptoms of low blood sugar, craves sweets during the day, irritable if meals are missed, felt shaky, jittery, or tremors throughout the day, agitated, easily upset, craves sweets during the day. So these are all low blood sugar symptoms. So we're suspecting she's really more on the hypoglycemic side. We look at this, and then we got to look at the severity, and we got to look at the scale. Now, let's see where we are here. Okay. The initial clinical step for 1 week is I'm waiting for a lab test to come in. I told her, listen, I want you to eat every 2 or 3 hours, every 2 hours with high protein, high fat, and high fiber, hybrid foods, and no sugar at all. And let's see what happens in the next week as we wait for your lab test to come in. So we ordered a series of lab tests with her to see what's going on. And I'm trying to figure out where she's at. So her lab tests come back after she's been stabilizing her blood sugar for a period of time aggressively. And here's what we see with her. Her glucose is 80, below 85. Her HbA1c is low, her LDH is low. So even when she was eating a very high-fat, high-protein diet, we couldn't see a change in her glucose levels. So she's definitely hypoglycemic, and now she's leaning towards hypoglycemia from some kind of underlying metabolic imbalance because the dietary change that she was following like that didn't have any significant effect. And then if we look at her follow-up lab testing, the other key thing that's significant is take a look at it here. Her RBC is normal, her hemoglobin, hematocrit, MCV, are all depressed. And she basically has thalassemia. And thalassemia is a red blood cell disorder where the red blood cells can't carry oxygen. And if you can't carry oxygen, then your mitochondria has a very hard time making ATP. And if you remember the citric acid cycle, oxidative phosphorylation pathways, when you take glucose, you make 36 ATPs, but it uses 2 ATPs to end up with 34 ATPs. And most of that ATP comes from the mitochondrial oxphos pathway. Well, she doesn't have the mitochondrial OX-phos pathway because she can't get oxygen to her cells. So she has to quickly burn sugar all the time for glycolysis. So this is a person who has her thalassemia really promoting her hypoglycemia. And that's what we're stuck with. We're stuck with a patient who's got hypoglycemia secondary to a red blood cell disorder. And then our goal was to try to see what we can do. Now, some thalassemias have been reported in the literature, if you put them on high amounts of antioxidants, that you can get some changes in the red blood cells so they can carry oxygen more efficiently. But anyways, once we're done with the workup, so here's what I found with her. Her brain, I did a very thorough neurological exam head to toe. There was nothing wrong with her brain. She just wasn't getting fuel to her brain. And then what we did is we identified she had this hypoglycemia pattern and she was constantly dealing with this. And even if she ate frequently all the time, she still would be in a hypoglycemic pattern. And most of that was secondary to her thalassemia. So this was the impression of my report. So the names are always whited out on these in case you're wondering why the slides look like this. Examination today found no evidence of any neurological disease or any patterns associated with neurodegeneration. It became apparent during the examination today that she has reduced brain endurance. Repeating testing with ocular and motor function exhibited predictable decay in neurological function associated with patterns of reduced brain endurance. When you see someone who's got lack of fuel into their brain, if you keep repeating the same test, then they start to break down. That's a major sign of poor endurance to the brain. It appears that she had impaired brain function, maybe due to lack of optimal fuel to the brain involved with functional hypoglycemia and lack of ideal oxygenation. Her pattern of thalassemia has impaired her red blood cell oxygen carrying capacity. Her significant hypotensive pattern, her blood pressure is 85/67, can lead to reduced cerebral oxygenation from lack of tissue perfusion. Furthermore, her circulation is inefficient, and there appears to be patterns of impacting her cardiac output associated with mitral valve prolapse. So she has low blood pressure, she has a mitral valve prolapse, and she has thalassemia. The initial phase of case management will involve using natural compounds to support her glutathione recycling, activation of endothelial nitric oxide synthase pathways, overall antioxidants, anti-flavonoid support to examine if these modifications can impact the expression of thalassemia red blood cell markers. Furthermore, careful attention to improve her hypertensive patterns per circulation and functional hypoglycemia will be the initial strategy to support her brain. So what I want to do is I want to keep her blood sugar level stable, but I got to see if I can change her thalassemia. So there's a couple things we did with her. We had her continue eating regularly, frequently with high-fat, high-protein meals to stabilize her blood sugar levels. I wanted to get her blood pressure up to get her perfusion improved so to get blood flow to her brain and to the rest of her tissues. So we had her increase sodium in her diet. I put her on several different supplements. One of them was Adrenostem. These are all Apex products, Apex Energetics. Adrenostem is a natural compound that increases sodium retention because it has glycyrrhiza in there. Remember that 11-beta-hydroxysteroid dehydrogenase pathway? People that have low blood pressure and have low cortisol. We talked about using glycyrrhiza. So this is a glycyrrhiza. I gave her a compound to help support B vitamins and nutrients to help stabilize her blood sugar patterns called Pro-glyco-SP. I put her on a product called Glutathione Recycler that has all the compounds to help recycle glutathione. I put her on liposomal glutathione called trisomal, and then I put her on a high amount of resveratrol and turmeric to give her lots of antioxidants. The glutathione, resveratrol, turmeric, and even nitric balance are all there to help improve her red blood cells. See if I can get enough antioxidant support to support her thalassemia. And the reason I did that is because I did a literature review and found that some patients with thalassemia, if they're given high amounts of antioxidants, can improve their red blood cell oxygen carrying capacity. If her red blood cell oxygen carrying capacity can improve, then we can get more oxygen to her mitochondria. So then she could have the ability to stabilize her blood sugar levels and see how things improved. So this is some of these studies where they show glutathione and vitamin E can help dampen the oxidative stress of thalassemia. But so that was their strategy. So here's the first follow-up test, and we see no change in her thalassemia. We increase the dose, no change in her thalassemia. We try again, no change in her thalassemia. Clinical failure. Couldn't do anything. So I referred her out to a friend of mine to give her IV antioxidants to see if that would help. Not helping. So this is a situation where we have a hypoglycemia patient secondary to thalassemia. Her thalassemia is significant enough where she can't carry oxygen. We can improve the quality of her life by stabilizing her blood sugar level, but we can't correct it. So real life scenario. They're not always home runs. You only can do what you can do. But I wanted to share that with you because I wanted you to see, this is how it is. Sometimes you do the best you can. You can improve quality of life, but the underlying conditions don't allow you to make that change. Let's get into case number 5. Case number 5 is the one you have in your case report that you may study in. And case number 5 includes Wade. And Wade is a 9-year-old boy who was diagnosed with type 1 diabetes. And the summary of this case is that Wade's parents, and Wade's dad is a really talented sports medicine chiropractor. And once his son got diagnosed with diabetes, they called their office right away and wanted to get him in and get a really thorough functional medicine workup and how to manage his case. So I'm not going to read the whole history and summary to you because it's all included in your notes, and hopefully you read that before this course. But basically, he was diagnosed with type 1 diabetes, and they were looking for clinical management of what things they can do. They think their opinion of what could have happened was they have a combination of sensitivity to casein in their family history. Casein is one of the key things that increases risk for type 1 diabetes because it cross-reacts. They went to see a pediatric endocrinologist who immediately started treatment for type 1 diabetes, and they wanted to know what other things they can do. Here's a lab test of Wade. When you look through it, you can see that he has some electrolyte imbalances. You can see with some of this test, you can see his glucose is 265, extremely elevated. Kidneys are okay. White blood cells seem to be in the appropriate range. Red blood cells are okay. HbA1c, 12.3. That's significant. That's severe. That's a significant glycation. That's from the autoimmunity, so that needs to be managed. And that's not going to be managed in the conventional model. Glucose levels, 215, very, very high. Glucose 193. Again, glucose 115.1. And then you can see the immunoglobulin A count was was elevated. And you can see lymphocyte panels and monocytes, eosinophils, basophils were within the laboratory reference range. And then here you can see insulin antibodies themselves were right on the borderline. And then he had demonstrated antibodies to GAD65, very, very high. And islet cell antibodies, they're very high. ZN2 antibodies, they're very high. And they did some other testings. But these labs just confirmed that he has diabetes, and type 1 diabetes is clearly established. He has basically all the positive antibodies to the pancreatic target proteins and HbA1c. So what we did with him is we went through a diagnostic workup. And ultimately, we wanted to make sure we got C-peptide measured regularly, his ferritin levels to look for acute ferritin reactions. We wanted to check a lipid electrophoresis to see if he had any kind of genetic issues. And we ran through some tests. He didn't have any patterns of intestinal permeability, which is great. We suspect, always suspect with type 1 diabetes. We checked his blood-brain barrier, they were intact. And remember, if he's got GAD65 antibodies, I'm worried about neurological autoimmunity, and I'm worried about chemicals. He had no chemical immune reactivity, which is also great. But we, again, glucose high, hemoglobin A1c levels are high. Those have come down over time with management. And then we checked his immune cell function. They were okay. So we put him on some nutritional supplements. And what we did is we tested him with certain foods that cross-reacted with GAD65, IA2, and let me show you his treatment plan. So we had him continue taking EPA, DHEA. We put him on Enzymix Pro to help him digest his foods. We put him on a product called Glycine Synergy to help stabilize blood sugar levels. We put him on short-chain fatty acids, and we put him on potassium. And the goal was to reduce his HbA1c levels to less than 6.9, identify his baseline C-peptide, monitor his ferritin levels, and improve his microbiome diversity. And what we did is we did the rate 10 and removed the foods that he cross-reacted to. And at this point, we managed the case back to Brett, who is also a chiropractor, and he was able to continue with the care, and this is 1 year follow-up. Okay, hi Brett. Thanks for helping all us out and helping us educate each other about how to manage diabetes. I know that your son Wade's almost going to be 9 in a couple of days, and I saw him last year when he was 8. And when he came in, you'd already done an excellent job with your own background, with cleaning up his diet and putting more on a low carbohydrate diet, and you put him on green tea, B vitamins, and fish oils and multivitamins. And you and Lindsay had really just focused your attention on his care. And then you came down to just to kind of look at strategies in much more detail and see if anything was missed. And it's been about a year. And when we got finished with the workup and evaluation, we went through and basically found he was actually in pretty good shape, that despite having, type 1 diabetes, he didn't have any chemical immune reactivity, he didn't have any neurological autoimmunity in other tissues, he didn't have any hard neurological signs. Sometimes with GAD65, you have some basic ganglionic signs. He had a little bit of hypotonia with pendulum reflexes, but most kids his age do. It's not clear enough at his age if that's any issues, but there was no any signs of neurological deficit. And then at that point, we really just wanted to focus on the only thing that seemed like we could have added into the protocol, since we didn't have any chemical immune reactivity or other autoimmunities of any neurological disease, and all the other lab tests were coming normal, was just trying to focus a little bit more on his oxidative stress and his inflammation, because his lab work showed a little bit higher than normal ferritin. His HbA1c was a little bit was elevated. I think it was 6.9. Is what the numbers were. And we wanted to get a baseline C-peptide and then really focus more on the autoimmunity. And the protocol that we had was just to continue with the fish oils he was taking and then really improve his immune tolerance a little bit, and then have him take something called glycine synergy with the fiber and blood sugar support, and then do the microbiome mashup, take some short-chain fatty acids, and if you had a salty meal, take potassium, just the fundamental things for autoimmunity. And that's kind of where we left it off. So in this past year, fill us in.
Yeah, I would say, he continues to shock everybody that he sees, whether that's the endocrinologist or, other people that we talk to. There's, of course, many different help groups for type 1 diabetes. And, what the typical patient's worries or parents' worries is not ours. I think the biggest thing with our son is we wanted to avoid, obviously DKA and some of the more life-threatening complications with it. And because of, the advice you've given us and even my research before, that is really not a worry. Because we just have to use so little insulin, I would say that the main thing I wanted to get from you, Datis, was, like any autoimmune disease, is what is the driving factor? What are the causes, And so, you really, I think, did a great job of helping us kind of know like what we were dealing with and things like that. Because really, as everybody on here probably knows, there's probably 1,000 different things at least that could drive autoimmunity. And we genetically, we don't have great genes. I have type 1 diabetes in my family, and we have a high prevalence of Graves' disease on both sides. So, and actually my wife currently had Graves' disease when she had birthed my son, Wade. So anyways, we knew he was a little bit high risk, and we thought we were doing everything, to our knowledge to ward off anything. But, it was one of those things. And to be honest, it was literally the worst day of my life, when I got that diagnosis, just because I kind of knew what that entailed. But I would say that for anyone who's, worried about a new diagnosis or treating patients with it, I think because the symptoms are so scary with DKA, that people are afraid to get or to see someone who specializes in functional medicine. I think they're just a little bit nervous, and rightfully so. And that's why, I knew who Datis was, of course, but I knew that, I wasn't just going to take advice from anybody, and I wanted to be sure we were doing it right. The one thing we found out is Wade is living a perfectly normal life. He and to be quite honest, if we didn't have to tell people about the warning of DKA and some of those symptoms and signs, I honestly don't think anybody would even know, that he has it. He's living that normal life. So he takes a little bit of long-acting insulin at night, usually 1 unit. But as far as the fast-acting during the day, we really usually don't have to mess with that unless he's sick, he hasn't slept well. Every once in a while, he'll get a little bit high if he's, been in a soccer game or something like that. But I would say, so far that I have been just blown away of what's possible. And I think of all the autoimmune diseases that are out there, the one that I think that we know the least about as far as like good functional medicine treatment is probably type 1 diabetes. So I would say there is literally a canyon of possibilities for these patients.
And what were the experiences you were having with your son's endocrinologist? Were they're just in shock that he's not getting worse and he's thriving and he's growing? And
well, it was just fascinating. I mean, the first night in the hospital, like we had all these ratios, and of course we picked up that, right away. And I thought at the time, I'm like, this is pure insanity. But so if you talk to the endocrinologist, they'll acknowledge it, but they just, I don't know, I hate to say this, they just kind of dismiss it, like they just do. And they almost dismiss it as like, our son's the outlier. Early on, they dismissed it to the honeymoon phase of the disease. They would just say, oh, well, this is just the honeymoon phase. And I wasn't sure either. So I, kind of just was led along that way. But so that I would say, put it this way, they're not referring to, and by the way, for those of you who don't know me on this, I'm Brett Winchester. I'm a chiropractor, and I kind of specialize in the manual side of chiropractic, but we have a functional medicine wing or department in my office. And I would say that they're not just sending us a bunch of referrals. However, where we are getting a bunch of referrals is that everybody is seeing my son, and they see how he is. So if anybody in like our area, the St. Louis area, has type 1 diabetes, they usually get referred to our office, but it's never, of course, by the endocrinologist.
Right. Yeah. It's
that might change though. I mean, in other autoimmune diseases, we've definitely been able to, break those walls down, but so far they're not grabbing on yet, but I'm young enough that might change.
That's great. And how's Lindsay handling everything? I know she's very active in Wade's care and everything. And
yeah, just great. I mean, like I said, we were both just, you take a month to just like realize, what went on. And, but yeah, I would say she's done great. And it just takes two good parents who, are both on board. And I think Datish, you did a great job of explaining to us the importance of that, because you really need both parents on board for this to go the way that everybody's going to want it to go. And then you also have to, the other part of it that is really difficult is to motivate your child. Wade was 8 at the time. Now he's almost 9. So, that's a skill within itself. These people who are seeing patients, they understand that also. So getting your patient to do what you want in compliance is another, that's a different animal also. So, having the right imagery and things like that for them to help them with Wade was really important. And analogies were really, really helpful. Goals with him. I think one thing that really helped with compliance with Wade was just kind of explaining to him, like, you're one of 10 people in the world probably who are taking this approach. So you're really special that you get this opportunity. And, you're going to be able to change so many people's lives with type 1 diabetes. And to be honest, once we made all the changes that you recommended, he really didn't push back like you would think. But part of it is we're also in that lifestyle also. So, we're not, pounding 400 carbs a day ourselves, and he's not having to witness us do that. I think that's also really, really important. And you hit that home in our consultation.
Yeah. And I thank you for sharing that, because I think, when you're yourself a doctor and then you go and see someone else, it's a totally different perspective. And it's good to really stress out to practitioners that are all trying to figure out how to help their patients how important the report of findings is, how important it is to, everyone can run labs, everyone can recommend supplements, but really to really understand the clinical model and like what is at stake here and what are the steps that need to be taken. Like that's such a key part of clinical management, right? And it's easier to do when you have intelligent people and parents that are educated and are really motivated, like of course in your family where you guys were just needed to make sure nothing was missed. But that is a key point. I think a lot of practitioners should really, I think, understand how important it is to really explain the steps that the family members need to take, right? And having your your Wade, having Wade, your son, not see that it's any different. You and Lindsay are both eating the same kind of foods and healthy, and it's not like a weird thing for him.
No, we actually spin it in a really weird way. Like we say, Wade, this is a huge blessing. Like it's actually, at some point you're going to look back at this and you're going to say, I'm glad I got type 1 diabetes, and you're going to be able to fill in the blank. And he really grabs onto that idea. And I think that's really important with all patients with autoimmune disease, when they get the death knell diagnosis and they think their life's over, to really, be the voice of reason and definitely not snow them. But, that's where I love, the functional medicine approach about finding out what's wrong and then treating that accordingly. And that's what you were able to do with Wade with the Cyrex Labs testing and the LabCorp blood work, because really I think the mistake a lot of people who do functional medicine make is they have kind of this panacea approach to patient. And I feel like you were able to test everything out. And I think because of that, it's very reassuring, because that way you kind of know what track to go down. And like Wade, he really had, as you said, he had decent blood work. So, we didn't have a bunch of findings on that Cyrex Labs, but if you hadn't ran that test, I would be wondering in the back of my mind if some of those things were at play, and whether or not we should be addressing them or not. So yeah, I hate to say this, but without the testing, I feel like you'd be guessing in a way. And then to your point, the implementation and having, the person who's selling the, whatever you need them to do is absolutely critical. I think, Datish, you benefit from your reputation, so people are going to listen to you no matter what. But the rest of the people, it's tough to do to get, obviously, as people to do exactly what you want.
No, I understand, and thank you for sharing that with us. And I think it's really important, when I remember the morning when I saw Wade, I'm like, okay, does he have neurological demyelination? Is Wade going to suffer from developmental disease? Does he have basic ganglion disease because GAD65 is there? Are there any other autoimmunities anywhere else? Is he? And he wasn't, and he was safe. And you guys have implemented everything immediately. And I believe it's going to completely change the trajectory of his health. And your family has history of autoimmune disease in it. Right? You have celiac disease, you have hyperthyroidism, you have Graves. It's like, if it wasn't this now, it would have been something at some point based on just genetics and the environment. Right. So,
yeah.
So you were able to catch it early as a family implement. He now knows that lifestyle. He's not going to know anything different. And he's going to be, one of these people that really has a terrible underlying disease like autoimmunity, type 1, but he's going to thrive with it, and he's going to keep it at bay, and he's going to function very high, highly with it. And like most people say, don't even know.
Yeah, I think the other thing, Datis, and the people out there too, I think all parents, you always feel guilt no matter what. And, we thought we were doing everything right. Maybe we were, maybe we weren't. But I think your reassurance, I just think it's a good message to know that as a parent, you really, you got to watch what you say, because otherwise you could walk away from an encounter thinking, oh my gosh, I can't believe I did something to, have this happen, And I thought you were just so good with that. I was dreading for Wade to go there in a way, because I was, afraid I was going to hear, well, this is the 8 things you didn't do with Wade, and therefore that's why he got type 1 diabetes. And I think in functional medicine, that actually happens a lot, a lot of shaming of, of that. And then at that point, it's just that's just not productive at that point. So you didn't do that, but I think for anyone who might be listening, it's a good lesson to learn as far as coming from a practitioner.
Well, that's really good advice. Anything else you think it's important for other practitioners to know, being with your experience?
I would just say the follow-up, I think you have not type 1 diabetes honeymoon, but you have a honeymoon phase of, oh, I'm excited, we're going to do this. And then the long-term implementation is always a little bit trickier, I think. So, I think whatever you can do to keep your patients on board and motivated. And I would just say also, I learned a lot from my visit with you too, Datis, about, like I said before, the importance of testing and then finding out exactly what needs to be worked on and going after that. And I think that's where Cyrex Labs was just unbelievable to be able to rule all that stuff out. To me, it's so affordable too. Now that we're implementing quite a bit here, the patients really don't balk at it. I mean, you don't want to hit obviously 10 of them, but I mean, if you're able to hone in on, the key ones, I think people, they don't mind. I always thought people would balk at the price, and they really just don't.
Yeah, I mean, it's valuable information. Well, Brett, thank you so much for sharing your experiences and for allowing all of us to learn from you. And we're so all excited. I'm sure everyone's really happy to hear Wade's doing well. And again, thank you so much.
No problem, Betsy. Thank you for all your help.
Okay, so this was the key thing with that case that we just discovered was really how important it is to do a really good thorough exam report of findings. I'm going to tell you, when I was going through Wade's file, when you see one autoimmunity, you might see more. And GAD65 is an ugly disease that can really impact the cerebellum and basic ganglia, lead to all types of developmental disorders in kids, like hyperkinetic movement disorders or dyskinesias, and ataxia and cerebellar disease and coordination issues. And so, I was very concerned going into the exam. And then as we did follow-up testing, we saw that there's no other neurological antibodies. And I think one of the things that we can learn from Brett here is just how important a report of findings is, how important it is to develop a clinical strategy. And this is one of the things I think we just don't cover enough in courses. We're always talking about the diagnostic approach. But one of the key things that really makes patients successful is to be able to sit down with them and do a very thorough report of findings and explain everything to them in detail and then screen everything out. So that was a great outcome. I wanted to share that with you, and thank you to Wade and Brett and Lindsay for allowing us to have that case to be shared. Let's get into case number 6. So case number 6 is a 56-year-old female. She complains of significant weight gain, fatigue, and depression. Now, significant weight gain, you're probably thinking more of an insulin resistance diabetic pattern. So here's the lab test. Now look at this. The glucose is 91, but the hemoglobin A1C is 5.7. And low creatinine here, low sodium, low chloride. Low creatinine can happen because of just lack of muscle mass. And then the TSH is a little bit low. The rest of the immune panel, the rest of the chemistry panel is okay. And if we look over here, there is no chemical immune reactivity and a little bit of autoimmunity to collagen complex, a little bit of RA. So really what we have is a patient that was actually diabetic. We just had a low glucose at that time and had elevated HbA1c levels. So we're really looking at, this early stage. And the treatment plan we did with them is basically we had him just reduce their inflammatory vicious cycle, put them on a ketogenic diet. This person had a gallbladder issue, so we had to first improve their gallbladder and then put them on a ketogenic diet. And then we put them on supplements to help support his gallbladder, like we talked about in the GI course. And then we put him on enterovite, short-chain fatty acids to really improve his blood sugar levels. And then within a very short period of time, we're able to get that hemoglobin A1C back to normal range and control the blood sugar levels. So 6 different cases, 6 different responses, some positive, some negative, real life situation. And hopefully you can see that the key thing you have to remember with blood sugar disorders is you got to work through the cases. You don't know how they're going to respond. How they respond tells you the severity of their case, what things can change, what things can't change. And you just have to apply those principles to see if you can get some outcomes. So you're able to see a few different things here. You're able to see a patient that had end-stage severe diabetes with nephropathy and inability to clear HbA1c. We went over a case with GAD65 autoimmunity that responded really well to cross-reactive foods. We went over a functional hypoglycemia that had really nice benefits to stabilizing her blood sugar levels. We saw another functional hypoglycemia patient secondary to thalassemia that we weren't able to change much, but implementing a diet to stabilize their blood sugar made a significant impact. And then we were able to see Wade, who had type 1 diabetes. And the key thing with Wade is as long as they can keep that insulin levels to a minimum, he's not going to have any concerns for significant complications of diabetes that take place with hyperinsulinemia. And he's probably going to just by following the autoimmune guidelines and lifestyle, prevent a lot of autoimmune diseases that he's a high risk for, or at a very early age, which is going to be great for him. And then the last stage was just pretty straightforward insulin resistance. You just go through the protocols, go through the flow chart we discussed, and then you just do your follow-up testing to see if they improve. So those are the cases that I wanted to share with you in this course.